Thanks, Dr. Paritosh. In this brief presentation, I am just going to take you to certain salient features of history taking and what you should be looking at. So the topic given is sudden loss of vision and how to come to diagnosis. Now, causes of sudden loss of vision could be transient vision loss, where vision returns to normal within 24 hours, usually within 1 hour, or vision loss which lasts more than 24 hours. The causes would differ. Now, when it's transient vision loss, when it's for few seconds, it could be usually bilateral papilledema, or when there is papilledema, patient may get up with blurring of vision, or when there is a change in posture, the vision may be blurred for few seconds. Few minutes, classically we tell it as transient ischemic attack or amaurosis fugax. Sometimes when it's bilateral, it could be vertebro-basilar artery insufficiency. But when it's more than 10 minutes up to 1 hour, it's usually ophthalmic migraine with or without headache. Here patient usually can have some aura or something, seeing flashes or something. Now vision loss lasting longer than 24 hours can be sudden painless loss, gradual painless loss, or painful loss. Now sudden painless loss could be ischemic optic neuropathy, or more important would be artery occlusion. Now I say artery occlusion is important because sometimes in a busy OPD, the patient may have artery occlusion and he complains and you are busy, so his turn comes after 1.5 hours, 2 hours, and you realize that he has artery occlusion. So I think when you see a patient with marked drop in vision and there is relative afferent pupillary defect, there should be some way to shortcut and see that patient, especially when it's artery occlusion, because probably sometimes if you are lucky, do paracentesis and the vision may improve and the embolus or something dislodges, So I think this is important. Also important is when you are at home and patient says that there's sudden loss of vision and we call him next day for examination, or because it's Sunday. So probably these are the things to keep in mind. Then other cause could be vitreous hemorrhage due to any cause. Retinal detachment would not be so sudden, but patient may realize suddenly. And optic neuritis is another common cause, where there usually would be painful eye movements. Now, painful vision loss is optic neuritis, and most important is endophthalmitis, acute endophthalmitis, especially when you have operated a patient for cataract and suddenly he complains of pain and loss of vision. You have to suspect that it could be infectious endophthalmitis and examine that patient at the earliest, And sometimes it could be non-infectious uveitis also. Gradual painless loss of vision could be because of ARMD or diabetic retinopathy, or even vein occlusion can be gradual, or when patient suddenly closes one eye, he realizes that other eye he has no vision or less vision. Now this is a classic case of optic neuritis with optic disc swelling and engorged vessels. You will have relative afferent pupillary defect also, and color vision would be affected. Now this is classic cherry red spot, or this is infarcted retina. So this is all whitish in appearance. This is branch artery occlusion, and this is a thrombus here. Our friend Dr. Nishkant Bose had popularized vitrectomy and maneuvering this thrombus or massaging this, but I think it has not picked up well, and probably it's not having better curative rate compared to natural course. In a cherry red spot, you will see the entire cherry red spot here. So this is something, a medical emergency, and you need to investigate patient for systemic disease, especially carotid artery occlusion or thrombus or any valvular problem in the heart from where embolus can get dislodged. Now these are typical central retinal vein occlusion where the hemorrhages are all round, or there could be branch retinal vein occlusion where there would be hemorrhages in one quadrant. The vision loss is because of the macular edema. And this is a classic case of retinal detachment. There would be retinal tear and loss of vision. So again, history is important in retinal detachment, that intelligent patient will say that I am not able to see in a particular quadrant. I had a patient whom I had operated for detachment in one eye and had silicone oil removed. One day he says that he is not able to see again in the same eye in a temporal quadrant. So as a routine examination, we always dilate both eyes, and he had detachment in the nasal quadrant in the other eye. So this is important to know that you always examine both eyes. Patient may not realize which eye he has less vision. Now this is a classic case of vitreous hemorrhage where you can see the details of retina here in the periphery, and these are the hemorrhages which is obscuring the vision. So these are all photographs which we discussed of sudden painful loss of vision. Now chronic loss of vision, this is a case of wet ARMD with lot of scarring in the retina. Since you can see the blood vessels over it intact, it is subretinal scarring. So this diagnosis would be wet age-related macular degeneration in an elderly gentleman. Whereas here this is a dry macular degeneration, looks like dry, but if you see the OCT there is fluid. So this eye would need immediate treatment. Now this is classic diabetic retinopathy proliferative type, and this is diabetic macular edema, which again would present as loss of vision or gradual loss of vision. So these are the photographs what you saw. This is an extreme case of endophthalmitis, but minimal and minimal hypopyon you can miss, especially when patient complains of painful drop in vision. You have to look carefully on slit lamp and look for flare cells and hypopyon and vitreous haze. The treatment would depend on that. So when you examine the patient, you check the visual acuity, you see the cornea, whether it's clear or there is edema, you see the pupil reaction, especially RAPD would be there in optic neuritis and artery occlusion. You look for anterior chamber lens, IOP, because acute congestive glaucoma also can give rise to painful blind eye, and iris for new vessels, especially for neovascular glaucoma. You see the media for vitreous, whether there is vitreous hemorrhage or anything else, disc for optic neuritis and pallor, macula for edema, hemorrhage, and general fundus for retinal detachment or any active retinitis or choroiditis lesion or retinal hemorrhages. So I think with a proper history and proper examination, most of the time you can just come to diagnosis without any ancillary examination like B scan or ultra wide field photography. What you need is a detailed history and a careful open, your eyes to be widely open and mind to be widely open to come to a provisional diagnosis. Thank you for your patient hearing.
Thank you very much, Vatsal bhai. It was an excellent eye-opener. It's very important whenever a patient, particularly at the weekends or on a Sunday evening when the patient calls you with sudden loss of vision, you need to dissect out just based on history. And if it's a total blackout, then there's a very high risk that it might be a central retinal artery occlusion. Please drop your work and go and attend to that patient, because there's a good chance that you may be able to salvage something at least. And as Dr. Vatsal bhai mentioned, retinal angioplasty, the results have been kamsi kamsa. I mean, sometimes they work, sometimes they don't. But certainly paracentesis, good old paracentesis and digital massage and IV mannitol, it does work in many cases still, especially when there are not multiple emboli or a long embolus. Okay, so please, use the opportunity and save